Namaskar friends, welcome to the video. We will discuss menopause in this video. This discussion will be limited for undergraduates, and later detailed discussion on this topic will be covered in separate video, which will be for postgraduate as well as for practicing clinicians. Now what is menopause? It is the cessation of menses for more than 1 year is called menopause. Cessation of menses for more than 1 year is called menopause. So menopause is a retrospective diagnosis because no one can tell a woman that when her menses will stop in her life. But definitely there are some symptoms that start before the actual cessation of menses, and they are called perimenopausal symptoms, and that phase of a woman's life is called perimenopause. So what is perimenopause? It is from around 3 years before to 1 year after menopause. This is the time when a woman starts becoming symptomatic for menopausal symptoms, or you can say perimenopausal symptoms, and till 1 year post menopause. So this is perimenopause. A woman comes to you, suppose, with the symptoms of perimenopause or menopausal symptoms, and what are you supposed to do? This topic is important, menopause, because a woman may not come to a gynecologist for the symptoms that she suffers during her menopause or perimenopause. She may go to a psychiatrist, she may go to a family physician, she may go to a urologist, she may go to a neurologist, she may go to a surgeon, she may go to a skin specialist, she may go to an endocrinologist, because she is not aware that all these symptoms are because of menopause only. So everyone who is practicing in the society, they should be aware about menopause and what symptoms are occurring at menopause. So this is a brief topic for MBBS students and also for other physicians, like for urologists, neurologists and other specialties, to know the certain basics to remind them that menopause is a thing that they should always keep in mind when they are dealing with the woman who is around 40 to 55 years along with varied symptoms. So that's why this topic is important in your clinical practice. So what are the things? If a woman is perimenopausal and she comes to you for certain symptom, what are you supposed to do? First of all is counseling. Then you will counsel her for her diet, about her lifestyle modification. What modification? You ask her to do a weight bearing exercise for 30 minutes minimum daily. Weight bearing exercise, either cardio or walking for 30 minutes. So this lifestyle modification will help her to postpone the onset of osteoporosis and also in her cardiovascular protection. Now what else? You will measure her blood pressure. Then you will talk about contraceptive. Contraceptive advice should continue. What if she is IUCD? It should remain 2 years post cessation of menses. If she is using OC pills, combined OC pills, COCPs, then it should continue 1 year post cessation of menses, and barrier contraceptive also should continue 2 years post cessation of menses. So this is important. Contraception should continue, and for how long it should continue, she should be told about that. After that, what else you are going to do? You will be doing her breast examination to rule out any lump, and you will explain her to do regular self examination of her breast. What next? Her genital examination, pelvic examination, and to rule out any ovarian enlargement or any erosion or any early stages carcinoma cervix, and also you should subject her to pap smear. It is must at that time. What else? subject her for her CBC, sugar, thyroid and lipid test, lab test, biochemistry and hematology, and you have to evaluate whether she is requiring HRT or not. You will evaluate her whether she is high risk or not, and how will you evaluate, we will see in a short while. So what is menopause? I have already discussed. It is a cessation of menses for 1 year, is called menopause. So it is a retrospective diagnosis. So what is climacteric? Don't confuse climacteric with perimenopause. Climacteric is the cessation of ovarian activity. Okay, and what is menopause? It is also cessation of ovarian activity. You may think that the things, both the terms are interchangeable. No, climacteric is only related to ovary. Climacteric is only related to ovary, and menopause is, what is menopause? Menopause is a general term which is happening from her head to toe during that period, that perimenopausal symptoms that we talk about. So climacteric has to do only with the ovary. It is cessation of the ovarian waning. It is a gradual waning of ovarian activity which leads to ultimately her cessation of menses and menopause. So these both the terms are not interchangeable. So now what? Demography. What is demography? Almost a woman leads 1/3 of her life in menopausal period. So that's why it is also important, because long duration of a woman's life is in this period, and the symptoms which are very typical, and to these we have to take care of them, hitting at the etiology, not just symptomatic treatment, but try to hit at the etiology, and so that you get the maximum and the woman gets the maximum benefit. Now one thing that you should be aware about is straw. What is this straw related to menopause? In 2001 there was a workshop which is staging, STAGING, so staging of reproductive aging workshop. When did it happen? 2001. So what stages they suggested? 7 stages of reproductive aging they suggested, starting from -5 to +2. So -5, -4, -3, -1, 4, 3, 2, -1, +1 and +2. So there is no 0. 0 is not there in this staging, always remember. And what is -5? -5 is the onset of menses, that is menarche. And what is +2? +2 is 6 years post menopause, post last period, 6 years post last menstrual period till death. So these are the staging. So -5, -4, -3 it is the reproductive, -2, -1 is perimenopausal, and +1, +2 is menopausal. So these are the staging. And what is straw plus 10? This workshop was in 2011, that is 10 years after the first workshop, and this is a straw plus 10. In this they subdivided these categories for better understanding. So the detailed straw and straw plus 10 I will discuss in a separate lecture, that will be specially for postgraduates and for practicing clinicians. More so it will be for postgraduates, because they have to appear in the exam and they have to be best in their knowledge about the subject. So this will be discussed in separate lecture, you can get in the playlist. Now what next? Age. What is the average age? In India, it is 47 years. Average age of menopause in India, it can happen anytime 45 to 50, or you can say more than 40, it can happen anytime. If it is happening less than 40 years, then it is called premature menopause, and it is one of the indication for HRT. And if a woman is having delayed menopause more than 52 years, if she is having, then she is at increased risk for endometrial carcinoma and also breast carcinoma, and you should also monitor her accordingly. So what is the next pathophysiology? There is a climacteric phase, that means the ovarian activity is declining gradually. So what is happening? Graafian follicle, they don't mature, there is reduced E2 estradiol and reduced inhibin. This inhibin, it has got a negative feedback for FSH, negative feedback. But when this falls, this negative feedback is inhibited and FSH rises. What is the level? If you get more than 40 milli international unit per ml of FSH, it is indicative of poor ovarian activity, and moreover if you have low E2 levels. In clinical practice, we don't measure this inhibin in each and every case. We don't even measure this FSH if everything is occurring in time. But if suppose a woman comes to you at around 37-38 years, she says that I am not having periods, suppose 3 months period, she misses her period, 3 months of amenorrhea, and she is also coming with vasomotor symptoms, other symptoms of menopause, then yes, definitely at that time you will do this test to rule out premature menopause. So this is the pathophysiology. Detailed pathophysiology will be discussed in video for postgraduates. Now what? Hormone levels. E2 secreted from ovary, and E1 estriol, estradiol. It is from the peripheral conversion of androstenedione in adipose tissue. ठीक है, this estriol. So this E2 E1 ratio is more than 1 when a woman is fertile, reproductive age group. If this ratio becomes less than 1, that means E1 may rise or may be normal, but E2 will fall. So what is happening? This E2 E1 ratio, if it is getting less than 1 and FSH is high, more than 40 milli international unit, that is indicative of menopause. So you understand that estradiol, which is secreted from ovary, is less. Estriol, which is because of the peripheral conversion of androstenedione, which is secreted from ovary, is leading to, which has also got a little androgenic activity. That's why we see hirsutism in women post menopausal group. So she may, because of this hirsutism, so now you see she may go to a dermatologist also. Okay, so varied, it has got a varied clinical presentation, and to come to a diagnosis and to treat the etiology, you should be aware about the things that are happening during menopause. So what else? Risk factors that may, menopause is physiological, it is happening in each and every woman. So do we treat each and every woman of menopause? No, each and every woman has not to be treated. It is customized. We have to consider various things to decide whether treatment has to be initiated or not. So what are the risk factors for menopausal complications? Early menopause, that means early menopause, or you can say premature menopause. Then surgical menopause, If she has got already other risk factors for cardiovascular diseases, coronary artery disease, then if she is smoking habit or alcohol or caffeine. What next? Radiation. If menopause has occurred because of radiation or by chemotherapy, CT chemotherapy. So these are the risk factors that, or if there is a family history of cardiovascular disease or osteoporosis in a woman, then she is at risk. So she may need treatment. Now what are the changes that are occurring in menopause? Anatomical, there is atrophy of the uterus, atrophy of the fallopian tube, ovarian volume reduces, and what happens? The vagina, it also becomes pale and vascularity is lost, elasticity is lost, and it may lead to bleeding, dyspareunia, and endometrium is thinned out, only basal layer is remain. So these are all the anatomical changes that are occurring in the genital tract. Then what next? Because of this histrion, there is a fat deposition around the breast, waist and hip level. And breast, what happens in the breast? The glandular tissue, it reduces in the volume, but the fat deposition is increased. So the breast they become more pendulous. Glandular tissue is reduced. So what are the menopausal symptoms? Menopausal symptoms are early, early menopause and late. In early, what do we get? We get usually vasomotor symptoms like hot flushes, sweating and insomnia. Then psychological irritation, irritability, what? And lack of concentration. These are all the early symptoms. She may go to a psychiatrist for these symptoms if she is, or maybe she may go to a neurologist of these early symptoms. So typical hot flush, it is seen in almost 80 to 85% women, perimenopausal women. But because of lack of education, or we can say lack of access to healthcare professionals, they don't consider it a major thing. But some women, they develop it very severe, they even get it during the night, it disturbs their sleep, and this lack of sleep again causes other psychological impact, and the vicious cycle is go on. So it is typical that they feel heaviness in head, then followed by warmth in their face and neck, and followed by perspiration, and it lasts from around 2 to 5 minutes. And they are severe. If they are severe, they may even develop during her night, which may interrupt her sleep. Because of the vaginal and genital atrophy and vaginal dryness, she may experience dyspareunia, and this dyspareunia and other androgen levels, they may cause loss of libido also. So that may become irritating to her and to her partner as well. So these neurological, she may develop tics, tingling sensation along with these vasomotor symptoms. So these are the loss of libido. Then urethral symptoms. Urethral symptoms, they are so peculiar, similar to urinary tract infection. They may experience frequency or urgency. Then they may experience this burning micturition, and also urge and stress incontinence. So all these, they fall under a term urethral syndrome. You have to be aware about it. When a woman in around 40 to 55 year comes to you with these symptoms, and her urinary tract UTI, her urine analysis is pus cells are negative, and it becomes sterile, culture is sterile, then always think that this is the urethral syndrome, and simple local application of these estrogen creams will relieve her symptoms. So for this symptom, she may go to a urologist. So you should be aware about all these things. Then what are the late sequelae? Late sequelae are arthritis and osteoporosis. Number 1, it is, suppose we can say, bone related, then cardiovascular system, then CNS, coronary artery disease, stroke, osteoarthritis and osteoporosis, then skin, drying, hirsutism, and what next? Alzheimer's. What next? After Alzheimer's, colonic cancer. So these are the late sequelae that can happen, and the last one is tooth decay. So we will see them one by one. Number one is osteoarthritis. Osteoarthritis is age related, we all know. It is seen in men and women both. Osteoporosis is also age related. We get the maximum bone mineral density. Maximum bone mineral density is seen at around 35 to 40 years of age. In women, what is happening? The intake is less, and repeated childbearing, lactation, they may not attain the maximum level during this age, and because of after this age there is a gradual fall in bone mineral density. Even if your intake is adequate, then also there is a gradual fall. So osteoporosis is said to be when the bone mineral density is less than 2.5 standard deviation of the mean adult value. It is adult value. Suppose you have 70-year woman, you will not go for that this year mean value. You will be comparing it with mean adult value. And there is also osteopenia. It is 1 to 2.5 standard deviation less than mean adult value. So osteopenia, and gradually to osteoporosis. So there are, in cases of osteoporosis, there are women is at increased almost 50%, 50 to 70% risk of spontaneous fracture without any history of trauma. And how to diagnose this 2.5 standard deviation? Which site bone mineral density? According to WHO, it is lumbar spine. It can come as an MCQ in your NEET PG. Lumbar spine, bone mineral density. We do it 3 site, but to say it is osteoporosis, we have to do it at lumbar spine. Okay. So this is about osteoporosis. There is in women after the estrogen is gone, after menopause, this bone mineral density, which is falling gradually in both male and female, it falls very sharply up to 5%. Up to 5% fall, especially in trabecular bones. So she may get spontaneous either spine fracture, vertebrae fracture, or fracture of neck of femur. And this fracture of neck of femur, we all know it has got a very poor outcome. It has got a increased mortality, and this she may go to a orthopedician. So these are the things. So what are the risk factors that she is at high risk of developing osteoporosis? First is a family history of osteoporosis, age, then race, and low calcium intake in her diet. Then if she is multiparous and she has lactated all her issues, then low weight, sedentary lifestyle, then if it is a surgical menopause or radiation menopause or premature menopause, all these are the high risk factors for osteoporosis. Now this diminished bone mineral density, we look by DEXA scan. Okay, DEXA scan. So now what is another cardiovascular incidents? A woman who is already hypertension in her premenopausal age, she is at more risk. If she is obese, she is at more risk. If she has a high LDL value, she is at more risk. If she has another smokers, if she is a smoker, then she is at more risk. You have to identify these women and you have to give them the protection of HRT for that. Then stroke is seen more common after menopause because of this thromboembolic phenomena. Then skin loss of this estrogen causes, decreased estrogen causes loss of collagen and wrinkling is seen. So sometimes we see some women, they use estrogen creams to apply to reduce the wrinkles, but the effect is not long lasting, and ultimately what happens, the skin, it becomes thinned out and it becomes more prone for injury. So it is of limited value to do all these things. Now Alzheimer's disease, HRT has a proven benefit of delaying the onset of or even preventing Alzheimer's disease. So, and anocolonic cancers, they are more common in postmenopausal group. Then endocrine, because of this and higher estrogen levels, she is more prone for this hirsutism. And pyometra is more common in late menopausal stages because of the narrowing of the cervix, stenosis, and the collection becomes infected in the uterine endometrial cavity. So what investigations? Again, you have to take the detailed history, then rule out in family history, detailed family history. Also you have to look for her breast to rule out any lump. Then pelvic examination, if her ovaries are palpable, postmenopausal ovaries should not be palpable, always remember. Then her blood sugar, lipid profile, you may investigate thyroid, you may investigate for thyroid, and mammography may be indicated if she is obese or if she is more at risk of, if there is a family history. Ideally it should be done as a screening, but if you are not able to do it routinely because of the expenditure and other constraints, then you can subject at least high risk women for mammography. And then bone mineral density can be done, DEXA scan, to check whether for osteoporosis, and hormone, whether she is a candidate for HRT or not. Then what is the management of menopause? Counseling is most important. You have to tell her what is going in her body, you have to tell that this is physiological, and you have to during counseling you have to take detailed history of her symptoms so that you can focus on which treatment we have to initiate. This is very much important because the menopausal treatment, you get a list, but we will see now that this treatment will hit at this condition, this treatment will be beneficial for this condition. So you have to be the first meeting and first history taking should be very much detailed, so that you can guide yourself in the best treatment possible for her. So what if she is having more of vasomotor symptoms, then the treatment will be different. If she is having psychosomatic, then the treatment will be different. If she is having urethral symptoms only, then it will be local estrogen cream application, it will benefit it. If she is a cardiovascular risk, high risk, or osteoporosis, cardiovascular high risk, then you have to give oral estrogen, and so on. So who are the candidates that are for HRT? So first of all, counseling. Then for psychosomatic, if she is having insomnia, anxiety, palpitations, then what you will do, you may give her mild tranquilizers. Paroxetine is very helpful in relieving her psychosomatic symptoms, and majority of women, they experience a very good life with this use, and over a period of months and years it can be stopped later. Now what next? HRT. So who are the candidate for HRT? Each and every menopausal woman is not a candidate for HRT. There are some indications for HRT. So what is? Number one, those women who are symptomatic. Number two, premature menopause, women who have their menopause before age 40. premature menopause, they are women candidate for HRT, because they are at high risk for CVS as well as osteoporosis. CVS, then high risk, those who are high risk for cardiovascular diseases, that is hypertension, obesity, diabetes, if they have, they are all high risk for cardiovascular diseases, and they are the candidate for HRT. Those who are at high risk for osteoporosis, we have just seen who are high risk for osteoporosis, they are also for HRT. And fifth one is those who demand HRT. Some women, they want to retain their sexual activity for longer duration, they want to get this estrogen benefit for longer time, and they come to you that, oh, doctor, I want to take HRT. So you have to select the woman, you have to counsel them, and you have to explain all these women, if you are planning to start HRT, that what are the side effects you may experience, and that you have to be in regular follow up in HRT. HRT is not like that I have given you prescription and you take it continuously for years together. You have to be regular in your follow up if you want to take HRT, so that we can get the side effect if they are occurring at the earliest, and we can stop it, and you can be relieved of them. So HRT can be short term and long term. So short term HRT is usually beneficial for women who are having vasomotor symptoms. Then you can, or especially in cases of surgical menopause, you just did a hysterectomy and removed the ovaries which are already functioning. So there is a sudden cessation. So in that case, you will start with the short duration HRT of 3 to 6 months, and by the time a woman gets adjusted to the changes in her body. And what in cases of radiation menopause, if she has undergone radiation, it is also seen in cases of radiation that prematurely they get menopause, but it has been seen that after a few years, either 1 or 2 years, the ovarian function gets restored and it becomes they become menstruating again. So it may be temporary as well. So you have to explain that to the woman that, okay, now your ovaries have regained their activity. So what are the contraindication of HRT? These are the indications. Now you have to find that if you have selected a woman, what are the contraindication that you will not start HRT. Number one is if she is a case of already under treatment for breast cancer, or she has taken treatment for breast cancer and she is now relieved. Now what? Endometrial carcinoma, breast carcinoma, endometrial carcinoma, uterine carcinoma, they are all the contraindication for HRT. Then previous history of any thromboembolic episode. If she has thromboembolic episode, and if she has a liver disease history, she has a liver disease history or gallbladder disease, then she is a contraindication for HRT. Don't confuse that hypertension or diabetes are contraindication of HRT. No, they are not contraindication. In fact, they are the indication, because they will identify a woman is at high risk for developing cardiovascular complications. So hypertension, diabetes, obesity, they are not the contraindication, but you have to be cautious in women who have this. You may either use low dose, and you have to do monitoring, regular monitoring. So what is now treatment for osteoporosis? When to start? Sometimes it is said that the when she is menopausal, you start the treatment and it is continued till 60 years. But nowadays it is said that if you are planning treatment for osteoporosis, prophylaxis for osteoporosis, you monitor her. So you get that woman is getting protected only up to 60 years, and now life expectancy is quite high. So what is the present protocol? That you monitor her bone mineral density. When she develops osteopenia, you monitor her for 6 to 8 years, and then you start HRT, so that this effect, which was lasting till 60 years, can be increased beyond that. So initially you don't have to give at menopause only. If her bone mineral density she is not osteopenic, or even if she gets osteopenia, you monitor her 6 to 8 years, and then you start with the HRT, so that the this duration is prolonged. So what next? What are the cardioprotective effect of HRT? Because we know that estrogen, it reduces LDL and increases HDL. So it has got a cardioprotective effect. For getting this effect, we have to give oral estrogen. Local will not help. Local thing will not help. If you are giving transdermal patches, it will also reduce triglyceride. Oral will not reduce. It will not reduce triglyceride levels. This is a MCQ question as well. But if you are giving it transdermally, it will reduce this triglyceride level also. So it has got a cardioprotective effect. Now, what are the drug dosage and route of administration? So estrogen therapy, it can be started with equine concentrated estrogen, that is Premarin, which is available in the market in a strength of 0.625 milligram. You can start it daily, and you can increase it BD if you want to increase if you are not getting the response. In cases who are high risk, like suppose she is obese or she has hypertension, then initially you start it with this dose, and for longer period what you can do, you can even reduce the dose. Now what else? We all know that continuous estrogen will stimulate the endometrium and breast tissue and may lead to endometrial and breast carcinoma. So to counter this harmful effect, we have to add progesterone. Continuous estrogen and low dose progesterone are given. The name is Femet. What happens? This progesterone, this will counter the effect of estrogen proliferation of endometrium, and it will cause this endometrial tissue is saved from this estrogenic proliferative effect, and over a period of time it causes endometrial atrophy. Initially for up to 6 months you can get some bleeding with this Femet drug, but after 6 months it is generally amenorrhea follows. So this is the one thing.